I'm happy today to introduce our team who do a lot, who are in, day out. You have a resident who either had a fall, a fracture, they want to come back to work to walk again. They do an incredible job. We have also our, just must say this, we have our head of therapy, Rosalind. She has many badges on her shoulder in terms of rehabilitation and the work that she does. Incredible. Unfortunately, she's not here with us due to personal circumstances, but I have with me Karen, Rachel, and the therapy department. Please welcome the team from Hammerson.
Good afternoon, ladies and gentlemen. Thank you, Clemens, for your kind words. As Clemens mentioned, Rosalind is not here with us today, but she has left a message for us, which I'll share with you now.
Good morning, good afternoon, and good evening to those of you joining us in person, online, and our international audience. My name is Rosalind Gray, and I'm the Head of Therapies at Nightingale Hammerson. I'm really thrilled that we have time to focus on rehabilitation in care homes today, a subject that's really close to my heart. Although my name is listed as your speaker today, rehabilitation at Nightingale Hammerson doesn't happen without a team. From our occupational therapists to our physiotherapists, our dietitian to our moving and handling advisor, our household teams to our engagement and spiritual teams, and those working closely alongside us. I know the JDA with us today, and they're supporting us working with residents and staff with hearing loss, another subject that's very close to my heart. I am now going to hand you over to two of our fabulous team members, Karen, our dietitian, and Rachel, one of our physiotherapists. I hope you all really enjoy an inspiring conference, and I'll leave you with one thought today. By not risking anything, we are risking everything for our residents. So over to you, Karen and Rachel. Have a fabulous conference, everyone.
Thank you, Rosalind. So Rachel and I are going to be talking to you a little bit about rehabilitation in care homes, and particularly how we embrace it within Nightingale Hammerson. So before we get started, I would like you to join us on a bit of a journey and take yourself back a few hours when you were rushing to get here this morning, navigating terrible traffic on tubes, driving from Brighton, from Woking, from all sorts of areas far and wide, and put yourself in the place that maybe you were running to catch your train, or you were running to catch the bus, and we all know it was quite wet and slippery this morning, and you fell, and you broke your arm, or you broke your leg. The wonderful NHS picked you up in an ambulance, they shipped you off to the hospital, they've patched you up, and now it's time to get home. So have a think about how you're going to get home from the hospital. Have a think about how you manage when you get home. If you've broken your legs, do you have steps that you maybe need to navigate? How are you going to get up those steps? How are you going to cook food for yourself? How are you going to get to the shops to buy food? How are you going to carry on with your work? How are you going to get dressed? How are you going to have a shower, bath, whatever it is that you would usually need to do on a daily basis? Put yourself in that picture. And I know one of my colleagues walked in this morning for the first time in many weeks without her moon boot, and she had a renewed sense of freedom. And I can just imagine how frustrating it must have been for her trying to navigate through the normal day-to-day activities that we need to perform. So, yeah, for you or I, it may not be that bad. We may break an arm, we may break a leg, we may get patched up. But for most of us, we'll probably heal up quite well afterwards. And if it's a more serious problem, then we may well be offered rehabilitation that allows us to regain our function and regain our independence and get back to where we were once before. So if we look at the World Health Organization's definition of rehabilitation, they say it is a process aimed at enabling people to reach and maintain their optimal level of physical, emotional, psychological, and social function. And rehabilitation provides people with the tools they need to attain independence and self-determination. And I think that picture probably resonates with a lot of us in typically what we understand about rehabilitation. So how do our care home residents fit into this traditional picture of rehabilitation? Or don't they? Are our older, frailer people and residents offered the same opportunity that you or I are offered should we fall over and break an arm or a leg? Do they have access to rehabilitation? If they do they, if it's a resident living with dementia, are they then expected to go into a strange environment to receive rehabilitation from people who don't know them, who don't understand them, who don't know how to connect with them? And I think more often than not, unfortunately, those same opportunities are not offered to our older residents. So what happens to your legs when you break your arm? Well, we all know that any sustained period of inactivity is not good for us. And this little graph shows us sort of the typical time you would spend being sedentary. So pre-accident, you might have been sedentary for about maybe about 75% of your day, or not quite, but about 60%. But that first day in hospital, you're likely to be sitting for 99% of that day. Day 3, if you're still in the hospital, about 97% of your day. And if you're lucky, by the time you get home, depending on that support you've been offered and what you're able to do, you probably are still sitting for a large percentage of that day, between about 87% and 90%, which is a significant amount of time to spend sitting or lying in bed. So we know that being active is absolutely crucial for helping residents to maintain their quality of life, maintain their physical abilities, maintain their independence. And we know that particularly older people who are not able to mobilize are going to have a physical decline because of that lack of mobility. And statistics tell us that if we are 80 years of age and we are in hospital for just 1 week, that we are going to lose 1.5 kilograms of our muscle mass. You might think, oh, that's not much. I maybe weigh 80 kilos, so come on, 1.5 kilos can't be that much. It is significant. And we know that that equates to losing about 20% of the power in your quadriceps, these 2 large muscles in your thighs. That's one of the biggest reasons why our residents fall, is when they start losing strength in their legs. We know that it also equates to about 10% of their aerobic capacity declining. We know that being in bed increases bone loss. We know that it causes muscle weakness, which according to statistics can stay there for a long time and is difficult to regain. We know it increases the risk of that person having a permanent disability. And we know it increases the risk of the person needing further help and support when they leave the hospital. We also know that decreasing muscle mass increases the risk for pressure injuries, which can have dire consequences for our older residents. We know that immobility, once again, is going to increase the risk of falls. So someone who's already had 1 fall is now at risk of multiple falls. We know it increases the risk for malnutrition, sensory deprivation, and continence issues. So, NHS England, in their Rehabilitation Commission guidelines, say that a modern healthcare system must do more than just stop people dying. It needs to equip them to live their lives, fulfill their maximum potential, and optimize their contribution to family life, their community, and society as a whole. It is suitable and should be accessible to people of all ages and in all stages of their life, and can help them, amongst other things, to recover from an unexpected illness, to manage long-term medical conditions, or to learn how to self-manage their own medical conditions, to recover from major trauma, to maintain skills and independence, and to access advocacy that they may need. And this, because we are talking about it being suitable and should be available for people at any stage of their lives. This includes what we call rehabilitative palliative care. So empowering people with life-limiting and terminal conditions to actively manage their condition, enabling them to live fully and enjoy the best quality of life. And it's all about our residents having the best quality of life. The range and scope of rehabilitation is huge. It's not just about physical or movement problems, but it includes sensory problems, cognitive or behavioral issues, communication difficulties, psychological and emotional problems, and psychosocial problems, rehabilitation for medically unexplained problems that people are experiencing, and mental health conditions. And rehabilitation is not just about physios and exercise, but rehabilitation is the responsibility of each and every one of us who comes into contact with our residents. We all have an important role to play in their rehabilitation. And some of the people who play a role include physiotherapists, occupational therapists, moving and handling advisors, but also drama therapists, art therapists, clinical psychologists, speech and language therapists, social workers, engagement teams, the list goes on and on. So is it time for us to look at how are we determining whether someone is suitable for rehab or not? Is it time for us to rock the boat, to look at how we measure success in terms of rehabilitation, whether someone's actually been offered that opportunity? And do we look at different outcome measures? And maybe we need to move away from the traditional picture of physiotherapists and rehab suites and exercises and start thinking about other outcome measures and outcome goals and what's important for that person. And it doesn't mean that we're talking about that person necessarily returning to the functional status they had before that injury. It could be as simple as enabling that person to be able to come downstairs to the cafe and meet a loved one for a cup of coffee, or being able to do their personal care independently again. So why do we focus on what people want to do? Asked Pooh. Because, Piglet replied, we want to help them get the life that they want, not the life that we think they should have. So I'm going to hand over to Rachel, one of my wonderful physiotherapy colleagues, to tell you a little bit more about how we embrace rehabilitation at Nightingale Hammerson.
On to the real fun stuff now. So, how do we embrace our rehab model at Nightingale Hammerson? So we have a wide variety of residents here. That work with us. They range from our respite residents that we have for short-term stay, whether that be weeks to months. We have permanent residents who maybe suffer injuries here, or they actually come as a permanent resident in spite of what's happened out with Nightingale Hammerson. We have palliative care residents that come and stay with us and how we support them at the end of their life. And we also have post-hospital discharge, so those who maybe no longer can survive at home and they need the help that we can offer them here. So we support residents to participate in what they want and what they need to do. And we also speak a lot with the families. You know, our ones who have the residents who have dementia, who are their advocates? That's their next of kin, who have known them all their life. We work with them, tell us what they used to enjoy. You know, was it tennis? Was it reading in a library? So maybe walk into the library is what they're going to want to do. Let's entice them, work with the families. Prevention is better than cure. Oh, we love falls in over 80s and we really, really don't like them here, right? So we really do try to prevent them, and I'll go on a little bit about how we do this through exercise and what we offer here at Nightingale Hammerson. And we just do a lot of specialist, generalist and skill set development. We're recognizing potential in residents, also we don't just stop at when a goal is achieved. You know, what more can we do? What more do they want from us? And can we just keep going, you know? And we also look at how we practice. We use guidelines, we, you know, do lots of research, and we speak, we come to these things. We have MDTs, we have daily meetings, weekly meetings. How do we keep getting better? Rehab isn't only to physios and OTs. You know, we work with everyone. We really do. I was up the stairs before this meeting this morning doing an MDT before this started to give our input. So here we provide it's a private model that we work on. So we provide individual private sessions at the request of residents or at the request of family members with consent if we're dealing with capacity and things. So as you can see, this is pictures from here at Nightingale Hammerson in the top photo. That is our physiotherapy suite. And it is a great place. We really do love to have either fun, and we can have it as quiet as they want. We also have a lot of Frank Sinatra and Elvis on that TV. It really does help in engaging people. You know, when we're cycling, what do they want to watch? Let's keep them going. Is it distraction? How do we really tailor these sessions to our residents and what they want to see? And during COVID, as we touch on that, I worked in the NHS. We've seen a lot of these disciplines and services disappear. We no longer had the time to give to just solely physio or rehab. It was, how do we discharge? How do we get people out? How do we just keep turning over? But having this space and time to dedicate to do what they want, how they want it, and this is just one of the places where we do things. Our group exercise sessions, as if you ask any resident, it is a stone in the calendar of their week. It does not move, and if it moves, we're in trouble. Okay, we run it every week in here, and they absolutely love it. And we also run one on a household, because what we like to do is let's try and adapt and meet all the needs of our residents. We know that we vary differently physically, mentally, cognitively. So how do we cater to all of this? So, we try, fail, just trial and error. So, it works. We have one down here, we have one on the household. Let's cater to everyone's needs and really try our best. I'm going to just show you a short clip of what we do. So as you can see, there's some in wheelchairs, some in chairs. We have a variety of people that attend, and it's inclusive. That's what we try and do. And it's a massive part of people's rehab programs, as well as one of our falls preventions. So, it might be people that are having quite a lot of falls, and we really do encourage them using the staff household. Right, let's get everyone involved. Let's get them down. Let's get them doing this. And it's a very good social aspect, actually. You'll see many of them go out, have a coffee, have a chit chat. It's a great way to really get everyone together. And it's a little community. It brings all the households together. It's lovely to see. And they don't like it when it's cancelled for some event. I can promise you that. And I'm just going to move on to the next one. Here's some pictures of our lovely residents engaging in some of our exercise. So we always say rehab can and should take on whatever shape and form is important to the resident. We know that we have that therapy suite. Okay, some people like their exercise. They want to do it in the gym. They want to feel like they're working the whole time. Other people, what's important to them? Okay, let's reach a goal. Let's go outside and walk. Let's do it in the bedroom. Let's stay on the household. Let's, investigate what you have to live in. Where's your shared space? Let's do it together, And they really do appreciate it, but not today. Falls risk with the rain and the leaves. This one. It is a joint effort with rehab. We do one part of it. We work with the doctors, we work with the household staff, we work with the dietitian, we work with the pharmacist. We have to all work together. And when things align, that's when we really start seeing progress, okay? A few case studies now from residents that we have actually worked with. So first one is a resident that we had on a respite stay for a couple of months. So they came to us following a fall, and they suffered a lumbar fracture, was for conservative management, so no operation, no brace. Where do you go from there? Like Karen mentioned, right, you're ready to go home. What happens? They were not safe to go home by themselves. They could not manage. They came to us following our assessment. They needed 2 people to help with them do anything. Okay, they barely had sitting balance. Could you imagine not being able to sit on the edge of your bed? That's where they were starting at. What were their goals? They wanted to be able to travel again, very specific, but this was the level this person was at. They were independent, okay? And they wanted to go back home. This was a short stay, work with us. So through personalized rehab classes, they attended the group exercise classes. We gave them exercise sheets. So how can we get them to start doing it independently? How can they transfer this into their own time and not be relying on us to do everything? And we did a lot around pain management with this person specifically. So we worked with the pharmacist and the household staff to get them to have their pain relief prior to the session. Let's maximize things, okay? And they did go home and they were able to travel again. Permanent resident, one who is still with us, lovely. Fall at home, fractured arm. Again, weren't able to go home safely, decided to come here. They actually had their operation whilst here, returned back to us, and were working so well with the rehab team that they actually ceased their partnership with the hospital NHS, and they wanted to carry on rehab with us because it's on site. We know them very well. We can see them daily. There's no waiting times, nothing like that. It's so quick and very personable. We know all the residents so well and what really is meaningful for them. And they are now mobilising independently and have such a good quality of life here and really managing to engage in the social activities that are here at the house. And the last one of our case studies is a palliative care resident who did come to us for end-of-life care following a surgery that they had. They'd been immobile and nursed in bed for a couple of months. They'd kind of, this was what was going on. They were realistic, this is where they were at. But after a conversation, we realized, okay, what can we do? What do you want to get out of this? They wanted to be able to be more independent. So we worked hard, day by day, week by week. And they are now independently mobile. Their needs have reduced from nursing needs to only a residential level of care required. And we've actually worked with them enough that they have the confidence to continue with further treatment to better the end of their life experience and prolong it as much as they can. COVID trend, touch on it just a little bit. So everyone had to adapt. And what did we do? We educated residents, family, staff. We couldn't be everywhere at once, so let's all work together and really get a hold on this. We knew that isolation and immobility were all causes of reducing strength and muscle mass and likely to increase falls. With the therapy interventions, we had classes as much as we could, if that had to be on the households, because we couldn't have mixing of households, so we had to adapt. We had to provide therapy exercise sheets. Let's get everyone involved. The staff are great at encouraging everyone, stay active, walk around in the household, let's do this together. Although we have to isolate, we can still do it together. And exercise classes. And we did see that they did have an independence increase in their quality of life. And the advantages of our rehab in the care homes. So we've talked about NHS, we've talked about how we manage here. Overall, we're really allowing people to meet their functional potential. We're supporting them with their well-being and health. And we really are trying to improve their quality of life, reduce the falls and injury, reduce hospital admission, because we have a great on-site team where we work with the GPs, pharmacists. Let's see what we can do here before we have to go into hospital. And delaying discharge. We say, patch up in one day. Where do you go from there? Come back to us. Come back. It's your home. We can provide everything on site here if that's what they wish. But we also have so many great communication and relationships with the hospital. We have great GPs we can phone if we do a great assessment here. We've got someone, query fracture, in for an x-ray, home the same day if we can. And because they trust us, the residents trust us, the family trusts us to provide a great quality of care and that we can do it. And as Rosalind said, if you risk nothing, you risk everything. And thank you for listening.
Any questions?
Hello, my name's Anna Butt. I'm a nurse at St Christopher's Hospice. Now, just like you, we have rehabilitative palliative care in the hospice, and we've had projects going out to various care homes post-COVID to see if we could help with the mobility and quality of life. But and we have a very good gym at the hospice as well. But I would say my observation is that many care homes do not have those services, do not have those resources. They accept people coming out of hospital who may have fractured a hip, have had very limited physio in the hospital, and once they get to the care home, there's nothing. It may arrive 2 months later, by which time that person is totally deconditioned. I just, this is the ideal, and I think it's wonderful, but actually working with the reality sometimes is quite different. I don't know what your observation or thoughts are on that.
Yeah, so prior to working here, I actually did some work in care homes. I live south of the river, so a little bit in Wandsworth. And to see, how much we are used here as a team, we're relied on heavily from the staff. This person's coming back from hospital. What do we do? What do we do? They're not like they were before. And we're so fortunate to be on hand. In the community, they don't have that. They get discharged with what they're currently doing, and the care home just have to manage that. We're so lucky, and I think the residents really do, and the families appreciate that we're there on hand. So, okay, they were able to walk before, but now they need assistance. But let's review this. They can get better. And we also do encourage people that we can see them in, for instance, in the first week that they come home. Let's, if you want to work privately, but we never stop them from accessing NHS services, but I think we're very lucky here that it's on site, because the waiting lists are getting longer. People are frailer, they need help sooner. And I think here is a brilliant model to demonstrate how well it works and how many people we can rehabilitate to have a great quality of life here.
I think just to add on, the challenges may be there for, I'm a South African, so I shouldn't comment too much about governments and stuff, but I think the challenge is there to look at different models. I think we can see the success we've had. Personally, as a dietitian, as far as we know, I'm the only in-house dietitian in a care home within the UK, which is another unique position. And, one of the things we've managed to do is to reduce the spend on supplements within our Wandsworth care home by 50%. So that alone, the savings made in that alone could be utilized, potentially to place a dietitian in another care home. So, I think we need to start thinking differently about things. We need to recognize how important it is for our residents to have access to that rehabilitation, to recognize the fact that it's not always available, also to recognize the fact that expecting a resident living with dementia to receive rehabilitation in potentially a strange environment with people who don't know them at all may not be the best use of anyone's space or time, and looking at how we can do things differently.
If I may just add one comment on the private sessions we provide. Obviously, the residents, being a charity, the residents that cannot afford to have the private physiotherapy sessions, the charity covers the cost from that. So, we have a beautiful building that looks very luxurious, but you don't know who are the residents that have the means to pay, and the ones that don't have the means to pay. We'll provide the same care to everyone here. And there's a question from someone watching us virtually.
Yeah, so Rosalind says, well done, first of all.
Thanks.
And a question here. Allied health professionals traditionally look at jobs in the NHS and social care. Would you recommend allied health professionals consider roles in care homes, and why?
I can go for it. You can hop on if you want. Definitely. I've been a dietitian for 20 odd years, and I've worked in hospitals in South Africa as well as in the UK. So I've worked NHS, I've worked private hospitals in South Africa. I've worked in private practice in South Africa. I've worked 6 years for a catering company in South Africa, providing catering in aged care facilities, which is where my love for aged care and dementia stems from. And definitely, I think just the fact that Rachel mentioned is we're so much part of a team. I know Sherman, one of our households, I'm going to steal their slogan, which is teamwork based dream work. And it honestly is, none of us can achieve what we do on our own. And we've got such a strong multidisciplinary team that's an absolute joy to work with. And I think, it gives you the opportunity to develop new skills. So myself personally, I might not be a dietitian who's, doing rocket science. I may not be working out a TPN for a comatose patient on ICU with heart failure, liver failure, everything else, and having to work out to the gram nitrogen what they need to have. But I've had to develop a totally new set of skills in that I have to now try and get into the mind of a resident living with dementia who isn't opening their mouth at meal times, and having to try and recognize, are they not wanting to eat because we're doing something wrong? Or are they not wanting to eat because actually they're not hungry anymore, they're tired, they're approaching the end of life, food's not important for them anymore. So definitely, you know, I think people always look at care homes as being the poor sort of second cousins, but they're doing themselves an injustice really, because I think the amount of skills and knowledge you can get in that care home is amazing, but it's up to you. You need to go there and look for the opportunities and look for where you can actually make a difference. You want to add anything in?
I think you did a good job.
Let's hope so. I don't know which one was first. Sorry.
Thank you for the talk. It was really interesting. I just want to ask about the impact of your work with the care team and how you transfer your skills to the care team so that they are more effective as well. Yeah, and also particularly, you mentioned dementia. You know, the outcomes you have for people living with dementia, are they as effective as people who don't have dementia? Thank you.
Yeah, thank you. So part of our role as allied health professionals within Nightingale Hammerson is training. So, you know, we offer training. We've got our own moving and handling specialist, Joe, who offers moving and handling training. Our physios and occupational therapists are available to do sort of any on-demand or on-site training that may come up. So we may, you know, have a resident who's in a very specific type of chair, that may not be familiar to any of the staff. So we've got the specialists at hand who are able to provide that training, that opportunity to explain how things should and shouldn't be done. As a dietitian, part of my role is training. So I run a couple of sessions. One is on general nutrition and hydration, so trying to equip our care staff with the knowledge that they need to have to be able to perform their duty, as well as a mealtimes matters training, which is helping staff to understand the importance of supporting residents with mealtimes and how to support them correctly. And I think, you know, because we work so closely with our households and with the GPs and with the engagement teams, we're really all able to put our heads together. So I think most of you are probably familiar with the saying, if you've met one resident living with dementia, you've met one resident living with dementia. There's no one size fits all, and I think that goes for any resident in any case. So it is a matter of trying to understand what's important for that resident. How are we going to make that happen? And I think the benefit, like Rachel said, of us knowing that resident so well is we've got one male in our team, and we know certain of the residents respond really well to him. So Rodell will see those residents, you know, and we might have someone who responds particularly well to Pat or to Rachel. So we're able to help allocate.
I shake my head, they never do it.
Oh dear. We're able to allocate, you know, residents. We're also able to look at the time of the day. So, you know, if we know that a resident is going to be busy with personal care at 10 o'clock this morning, and they're actually only going to be ready and settled for us to see them after lunch, then we can plan that session to see them after lunch. So it's all about individualizing it, identifying what's important, and yeah, working together as a team to try and get to those outcomes.
Thank you. So this is more of an observation than a question, if that's all right, because it was music to my ears, by the way. Everything you said is just, if only we could have this everywhere. But I think my observation about the problem of getting rehabilitation in most care homes is that we have this health and social care divide in this country, and it's really bad now. So, and the funding, etc. So I think you've managed to transcend that divide in Hammerson, and I congratulate you on that. You have a truly integrated approach, and it is bliss to hear this and to know that your residents are getting. I just wanted to add something that I thought you might find helpful, because you kind of triggered a memory for me when I heard a presentation from an Australian care home under the Common Age Network. I don't know if, and they were talking about, I mean, I always remember this, they have personal trainers in their care home, not care staff. They're all called personal trainers. So their whole attitude, their whole ethos is about activity rather than the kind of what I call cotton wool care and this risk-averse problem that we were talking about earlier. And their research, I remember them saying, it reduces the length of time people fall into frailty because they have personal activity programs for every resident. And so it's completely in the whole of the care, inverted commas, the activity team. And then I just wanted to finally mention NAPA, because I'm an ambassador for NAPA, so because it chimes so much with the National Association for Providers of Activities. And I know you have an activity team. I know Alistair is here, but just to mention that to everybody, because there's a wealth of information on their website about meaningful engagement, activity, having fun, quality of life, all of that stuff. So it's I love the way you were saying how much joined up the work it is. It's not just about getting people on machines, and it's much more than that.
Yeah,
Thank you.
It's massively integrated.
Yeah.
A last one.
Yeah.
Yes.
Very brief question. The Montessori approach to helping people in dementia with care homes, do you have a view on it? Is it something that's being considered? And I'd just like to, do you know what I'm talking about? Yeah? The Australian model.
I've got to put my hand up and say, no, I don't.
Okay, so the Montessori system for dementia is an Australian model where virtually everything they do is enabling people with dementia to help, to sort, to, let's say, play games, but everything's in a bit of a mess, and people with dementia are encouraged to sort things, to help set the table and things like that. And I know that in some other care homes they are using that method, and I wondered if you'd considered it or looked at it at all, but it looks like the answer is not at the moment.
I would say that we've maybe not got the name of Montessori to it, but I think, definitely one's looking at enabling residents as much as possible. And I've certainly worked in, care homes in my experience as well. Yeah, where we've actually had a young girl who was in a care home, unfortunately, because there's no other suitable placement for her. And one of the things she used to do was lay the tables. And we've got residents who help with flower decorations and all sorts of things. So yeah, we probably don't have that name to it, but we're doing it.
Without the name. Thank you. Okay.
It's the Nightingale Hammerson way.
Thank you, everyone.